Good evening, and welcome to the Rogosin Institute's presentation on IGA nephropathy, empowering the patient, caregiver, and care partner with knowledge. I'm Dr. Jeffrey Silberswag. I'm the Chief Medical Officer of the Rogosin Institute, a national leader in the diagnosis, management, and treatment of kidney disease. I would like to thank you for joining us for tonight's event. We greatly appreciate your time and your interest in our program. We have over 200 attendees registered for the program. This is now our second webinar on IgA nephropathy. The program has been made possible by our gracious donors, Julie Lamb and Kapil Mather. We're deeply grateful for their support in making this program possible. It's now my great pleasure to introduce our speaker, Dr. James Chevalier. Dr. Chevalier is the director of the Jack J. Dreyfus Kidney Clinic at the Rogosin Institute, an assistant professor of medicine and medicine and surgery at Weill Cornell Medicine, and an assistant attending physician at New York-Presbyterian Hospital. Dr. Chevalier graduated from the State University of New York in Buffalo School of Medicine and completed his internal medicine residency and renal fellowship at New York-Presbyterian Hospital's Weill Cornell Medical Center. His primary goal is to treat a patient's kidney disease, decrease the stress on the kidneys, and to keep them working as long as possible. His second goal for those patients whose disease progresses to stage 4 and 5 of kidney disease is to assist with a kidney transplant and to use dialysis only as a backup. Dr. Chevalier's clinical specialties include glomerulonephritis, including IgA nephropathy, and polycystic kidney disease. And now it's my pleasure to turn the webinar over to Dr. Jim Chevalier.
Good evening, everybody, and welcome to the second webinar on IgA nephropathy. This time we're going to talk about avoiding the unwanted outcomes and talk about how to keep your kidneys working, including the medications. So I do have a disclosure that I have spoken a couple times for one of the companies that makes an IgA medication. A brief outline today, but we're going to start with a little bit of a review from our first webinar in order to understand some of the concepts that we're going to be talking about tonight. I think that this is one of the most important things that I want to get across, and I think most people on this webinar already know this, but for many years, people were told that IgA was no big deal. Sure, everybody knew that it could cause kidney failure, but most people with IgA did just fine in the thoughts of the medical community. Now we know that this is no longer true, and we're much more aggressive about trying to protect the kidneys in IgA nephropathy. All right, so from the first webinar, I just want to remind everyone, IgA is caused by the body producing these abnormal IgA antibodies, which then form clumps with our own immune system's normal antibodies. These clumps are called immune complexes, and they get stuck in the microscopic kidney filters called the glomerulus. Based on this way that IgA happens, a 4-hit model now explains how it happens, but it also gives us the places where we can look for treatments. So these 4 hits represent opportunities to treat and protect the kidney in IgA nephropathy. The symptoms, as you probably remember from last time, include foamy urine, blood in the urine, swelling in the ankles or other parts of the body, and high blood pressure. The only way to diagnose IgA nephropathy is with a kidney biopsy. The biopsy not only gives you the diagnosis, but it also helps determine the aggressiveness of the IgA. How much might be active immune system attacking the kidneys, and how much might be permanent irreversible damage. And that helps guide treatment in IgA nephropathy. The creatinine and eGFR in the blood and the protein in the urine are probably the 2 most important things that help monitor how someone with IgA is doing and help tell us how to treat. Now, we learned last time, and we're going to emphasize again this time, the optimal target for protein in the urine is probably less than 500 milligrams a day, and likely even less than 300 milligrams a day if we can get the protein down that much. All right, why is it called IgA nephropathy? Well, the first part of the term, IgA, stands for immunoglobulin A. That's one type of antibody that our body makes. This IgA is made incorrectly or wrong by the person's body. The place that's incorrect is the arrows over here. This points to the place where it's galactose deficient. You might have heard of the expression galactose deficient IgA antibodies. Sometimes it's abbreviated galactose deficient IgA or GD-IgA. All right, the immune system antibodies and the galactose deficient IgA antibodies stick together. These clumps of antibodies are called immune complexes, and they get stuck in the microscopic kidney filters. Nephropathy, the second part of the term IgA nephropathy, means damage in the kidneys. The damage is from these immune complexes, these clumps of antibodies that damage the microscopic filter called the glomerulus. The damage to these glomeruli can lead to inflammation, abnormal labs, symptoms, and if we don't step in and do something about it, can lead to permanent and irreversible damage in the kidneys. So, like I said, we learned last time that there are 4 abnormal steps, or what we call hits. The first is that someone with IgA accidentally makes some galactose deficient IgA when it's trying to fight an infection, like a virus or bacteria. The immune system makes antibodies against the galactose deficient IgA antibodies. The immune system's antibodies attack these galactose deficient IgA antibodies because they look wrong. They stick together in clumps called an immune complex. These immune complexes then get stuck in the glomerulus, the microscopic filter. This leads to inflammation that damages the kidneys. Every IgA nephropathy flare-up is like a punch to the kidneys. That's why we want to stop them. So the chat should be open. Why don't we try a true or false question for the group? Please feel free to answer in the chat. True or false, treating IgA nephropathy when the blood creatinine is normal can save more kidney function than waiting until the blood creatinine gets worse. True or false? I see a lot of trues, which I like. So true. So one of the whole purposes of this avoiding the unwanted outcomes lecture is to try to diagnose early and treat early. All right, true or false? In IgA nephropathy, having a lot of protein and blood in the urine is no big deal. True or false? Go ahead and answer in the comments if you'd like. I think everybody's got the right answer once again. I know last time people told me to make it a little bit harder, but I don't know if I wanted to make it really hard. All right, false. So last time we did talk a little bit about screening. And one of the things I think we talked about last time is that having blood and protein in the urine is not normal. But a lot of times I think that doctors will say things like, oh, blood and protein in the urine. I bet it's an infection. Oh, I bet it's a woman having her period. And a lot of times it's not investigated further. But I do think that we should do that, and we're trying to encourage more investigation of blood and protein in the urine. Similar in many countries, especially in East Asia, where IgA nephropathy happens to be more common, there's a lot of screening, even of school-aged children, looking for IgA nephropathy. In countries who have mandatory military service, a urine sample with blood and protein will actually lead to denial for the military service and leads to evaluation by a doctor. This is probably cost effective. And several people, including myself, have wondered if maybe college physicals is a time when we in the United States could do some screening and then evaluate any abnormalities in the urine. Now, as I often say, and I think Benjamin Franklin may have once said, an ounce of prevention is worth a pound of cure. So prevention. We know that an infection, usually caused by a cold or diarrhea, is the cause of an IgA flare-up. Now, you don't need to live in a bubble, but anyone who has an any autoimmune kidney disease, including IgA, has probably heard me say, stay away from sick people, keep your hands out of your mouth, wash your hands throughout the day, do not share a spoon, a straw, a toothbrush, razor, lip balm, cup with anyone, including your significant other. And then masks. So we know that using masks decreases COVID spread, which we did a lot of research. We, the medical community, did a lot of research during the COVID pandemic. So some of the statistics here are from a couple of the references that I have at the end, and it does show that we can decrease the spread of infections using masks. All right, prognosis. So international guidelines are currently being developed. These are the KDIGO guidelines for those of you that are familiar with that body. They have actually made 2024 guidelines for IgA nephropathy. They've been reviewed by the community, the public has given feedback, and the final version should come out very soon, maybe within the next month or so. In any case, they recommend that anyone who has a newly diagnosed, biopsy-proven IgA nephropathy gets a couple steps. The first step is to look for any systemic diseases that can cause IgA nephropathy and then treat them if needed. The next has to do with the prognosis. The reason that we're determining the prognosis means that how aggressive we need to treat the IgA depends on the prognosis. Now, some of these things we learned about last time, but we're going to review them briefly and then move forward with the treatments. But the big question is, should a person with IgA nephropathy get supportive treatments, medicines that suppress the immune system, both or neither? And that kind of starts with evaluating the prognosis and the aggressiveness of the IgA. Briefly, everyone should get supportive or foundational treatment. Everyone who has damage to the kidneys, meaning abnormal creatinine in the blood or protein in the urine, should get medicines to try to improve the situation. The prognosis and the aggressiveness, sometimes along with the symptoms, tell us when we should add immunosuppression to the supportive care. All right. So there are some other medical conditions which lead to IgA nephropathy. These are the medical conditions that should be ruled out before we start the traditional treatments, immunosuppression for IgA nephropathy. If a person has some of these conditions, treating these conditions should, in theory, get rid of the IgA without giving additional medicines to suppress the immune system. They can still get supportive or foundational treatments if they have abnormal labs like protein in the urine. So we went through this last time, but some of the examples include inflammatory bowel disease like ulcerative colitis and Crohn's, autoimmune diseases like rheumatoid arthritis, people that are allergic to wheat, celiac disease, or gluten allergy need to avoid that in their diet, certain infections that need to be treated, and then some cancers like lymphomas that can make bad antibodies. Last time we did go through the kidney biopsy and this MEST C-score, which tells how aggressive the IgA is on the biopsy. I'm going to just review it briefly this time in one summary slide, but basically this is a classification that tells us the aggressiveness based on this score. Each of the 5 letters gets a number after it. Any number that is not 0 increases the person's risk of kidney failure. So in general, 0 is the least aggressive form of IgA, and 7, when all the numbers are at their maximum, is the most aggressive form of IgA. Now, that being said, the pathologists who developed this classification told us that when the E or C are positive, that means that the immune system is actively attacking the kidneys. That means that giving immunosuppression will very likely have a good outcome on the IgA treatment. If there is a number, a 1 or a 2 next to the M, S, or T, that usually represents permanent, irreversible scarring that often can't be fixed, but does make the prognosis worse. So there are some people who think that the M1, E0, S1, T2, C0 is the worst score because it's the most scarring and irreversible damage with nothing to respond to immunosuppression treatment. It does not mean that I would not give medicines that support or support or protect the kidneys, but the question becomes whether or not adding immunosuppression will have more benefit than risk, and that's something that we're going to talk about when we get into the medications. Now, there is this other prediction tool that is suggested by the KDIGO guidelines. It's called the International IGAN Prediction Tool. On the right in the table are the things that go into calculating the risk. Using demographics, labs, blood pressure, etc., this can tell a person when or what percentage chance they have to have kidney failure or a 50% decrease in their kidney function. Like I said, this was recommended by the most recent international guidelines. Like I said, you plug these into a formula and it gives you a percent chance. Now, a few comments. I think most of these things are the things that we talk about over and over and over again. Protein in the urine, blood pressure, MEST C-score on biopsy are all the things that we know tell us if a person's IgA is more aggressive or not. Now, a lot of people with IgA have had IgA for more than 6.7 years, which is the maximum length of time that this works for. I think that this is a disease of decades. So a lot of times, many people who had their biopsy more than 6.7 years ago, this is an irrelevant tool anyways. All right, now let's get to supportive treatments. A lot of times people say, but what are you doing for me? If you're not changing my medications, what exactly are you doing? So this is what we're going to use for tonight. So on the left, this green square is going to represent our supportive or foundational care, which a lot of people call it. This is kidney protection. This is good for anyone and everyone with IgA. So this is the lifestyle stuff. This is the medicines that decrease the stress on the kidneys, supportive and foundational care. We will talk about immunosuppression, whose purpose is to decrease the galactose-deficient IgA, hit number 1, decrease IgA immune complexes, hit number 3, and decrease the inflammation damage from the immune complexes, hit number 4. The supportive care works mostly on hit number 4, trying to decrease the stress and prevent the permanent irreversible damage. So the current treatment protocol, as recommended by the international guidelines, are this two-prong, simultaneous, at the same time approach. So everybody gets the kidney protection, the green square, and many people get the yellow square as needed, but especially when IgA is aggressive or when the immune system is actively attacking the kidneys. Now, here's the trouble. It's really hard to tell sometimes if a person with IgA just has old damage from previous attacks and the scarring is what's causing the abnormal labs, or whether the immune system is currently attacking the kidneys and that's what's causing the abnormal labs. In any case, we're going to talk about the supportive care, or the green square, first. All right, lifestyle. Water, water, water. I know that most people want to talk about the medications, so I'll make the lifestyle relatively brief. At our first visit, we usually talk about drinking water, 64 ounces of water a day. It doesn't have to be water, but it has to be non-alcoholic, non-caffeinated beverage. That's about 8 8-ounce cups of water total, or of liquids total, and the coffee doesn't count towards your 64 ounces. Some pain medicines can hurt the kidneys. I think most people know that Tylenol and an aspirin a day are okay. Medications such as Advil, Aleve, ibuprofen, Motrin, naproxen do or can put stress on the kidneys. We ask you to avoid or limit these as much as possible. There are more medicines that are just listed here, including Celebrex and some prescription strength NSAID medications. That list is not complete. All right, diet, I know, is one of the most controversial things. The one and only thing that has been shown to slow the progression of kidney disease is a low salt diet. Specifically, a low salt diet is about 2,000 to 2,300 milligrams a day. If you cook everything for yourself and you do not eat anything from a package, that's about a teaspoon of salt that you could sprinkle on your food throughout the day. Going down to 1,000 milligrams is not necessarily better. There is a minimum that your body needs in order to function normally. Protein is extraordinarily controversial. I think the biggest problem is that a lot of Americans have made the formula into pounds. So it's actually 0.8 to 1.2 grams of protein per kilogram of body weight per day, not pound. But a lot of Americans have put pound in that formula on the internet that people read. So an average person who weighs about 70 kilograms can have about 56 to 84 grams of protein a day, depending on how active they are. Anything they eat more than that will just be peed out in the urine. If you smoke, stop. Please exercise regularly. All right, optimizing metabolic syndrome risk factors. True or false? Here's another question that you can answer in the chat. Most people with IgA nephropathy are more likely to die of a heart attack than to die of kidney failure. True or false? So once again, I got to say good job to everybody. The answer is true. All right, one more question. Which of the following is one of the top things that contributes to kidney disease? A glass of wine with dinner every night. B, low vitamin D level. C, obesity. D, chronically elevated vitamin B12 level. Go ahead and vote. Excellent. I think that anybody who knows my little talk about kidney disease knows that I talk about the top 5 things in the United States that stress the kidneys, and obesity is on that list. So again, in terms of lifestyle, at the first visit, we usually screen for some of the most common things that stress the kidneys: diabetes, high blood pressure, high cholesterol, obesity, smoking. And if somebody has any of those things, we try to eliminate them or optimize them. All right, now, blood pressure, blood pressure, blood pressure. As I think other people have heard me say before, when you have high blood pressure plus IgA, it's kind of like 2 plus 2 equals 5. It's actually very bad to have some of those metabolic syndrome risk factors on top of IgA nephropathy. It makes the IgA get worse faster. So the International KDIGO guidelines recommend a blood pressure less than 120/70. Again, much easier said than done. I do focus on the top number much more than the bottom number because my interpretation of the literature is that the top number correlates better with the risk of heart attack, stroke, and kidney disease. It is challenging for people to take enough medicine to get both of those numbers less than 120/70. Now, ACE inhibitors and ARBs, which we're going to talk about in a second, are good choices for all people who have protein in the urine. They've been used for about 40 years or more to slow the progression of kidney disease in people who have protein in the urine. Almost always the first choice for high blood pressure in people who have IgA nephropathy. All right. Do you have a 34-inch waist or less? For most men, that's the goal. And like I often tell people, I don't want you to stop exercising. People will say things like, if I exercise, I might get more creatinine in my blood. And I say, I promise you, my waiting room is not filled with bodybuilders and marathon runners. Please continue to exercise. All right. Now is the time that everybody has been waiting for. Now we will talk about the medications. Some that are tried and true, some that are newly approved, and some that are in process or in clinical research trials. Number one, IgA is a chronic progressive disease. What does that mean? People with IgA nephropathy have to deal with this for years and decades. And unfortunately, the disease can often get worse over years and decades. At the end, I have about 6 or 7 of the most commonly asked questions during the registration process, which I'm going to answer. But one of the things that people really wanted to know is how fast does this progress? And again, our goal is to diagnose as early as possible with early screening and early intervention so that the progression can be slower. All right. Why do international guidelines choose 300 milligrams of protein in the day? Hopefully everybody remembers from the first IGA webinar that your kidneys are a filter just like a pasta strainer. If you get holes in your filter, just like the pasta strainer, water will go through and other things will end up in the urine that shouldn't be there, like protein. The more protein in the urine, the faster the GFR goes down. So there's a little bit of a debate on how fast a person loses kidney function with normal aging. But for the sake of argument, I'm going to say that the average person loses about 0.5% of kidney function every year after the age of 20, just by having a birthday with normal aging. If someone has more than 300 milligrams a day of protein in the urine, a person loses more than 0.5% every year. That means that their kidneys are going to fail faster. Based on many studies that have studied like thousands and thousands of people with IgA, we know that if a person with IgA at the time of diagnosis starts to lose more than 1% a year, their chance of kidney failure is really high, more than 50%, and in some cases getting closer to 100%. We don't have time from the time of diagnosis to give people 5, 6, 10 years and then look back and say, I guess you were losing more than 1% of kidney function a year. So what we need is something that we can use immediately at the time of diagnosis, and that something is protein in the urine. Therefore, people who have more than 300 milligrams of protein in the urine should have it step it up a notch in their treatment to try to get the protein lower if they're not already maximized. The more protein in the urine, the faster the GFR will decrease, and the faster a person with IgA nephropathy will progress from stage 3 to stage 4 and from stage 4 to stage 5. All right. Now, I think we got to talk a little bit about the history of IgA and protein in the urine. So before 2007, like I said sort of at the beginning, a lot of people who treated IgA, including like prominent nephrologists, would say, yeah, IgA is really common, so there's a lot of people in the world that get kidney failure from IgA, but the average person with IgA, they do okay. None of the people that I diagnosed with IgA are on kidney failure, or are on dialysis now, or have kidney failure. It's all the people I inherited from the doctors that retired. Those are the people with IgA that had kidney failure, needed dialysis. And then in 2007, we had this Toronto registry. And the 2007 Toronto registry said that people with IgA who had more than 1 gram of protein in the urine were the ones that were more likely to have kidney failure. So again, I think a lot of doctors and nephrologists were like, okay, I'll just get the protein down to 1 gram. Maybe that's why those patients that I inherited from the doctor that retired had kidney failure, but none of my patients have kidney failure. And then in 2023, we had the RADAR study. It stands for the Registry of Rare Diseases of the Kidney. I know the letters are in the wrong order. I don't know why it's RADAR, but it is, and that's what it stands for. In any case, the RADAR study showed that even people who had more than 500 milligrams a day were going to be at a very high risk for kidney failure in their lifetime. It might be longer than a nephrologist's career, which is why a nephrologist might not see the time from diagnosis to kidney failure. But for the person with IgA, it's still a bad outcome to have kidney failure. So since 2023, the guidelines for protein in the urine in people with IgA and other kidney diseases has decreased. Now we say anybody more than 500 is at high risk of kidney failure. Anybody more than 500 really should be treated, increase the treatment if not already maximized, and the goal should be to get everybody less than 500 and try to get less than 300 if you can. All right, now we need to make one or two disclaimers before we talk about the actual medications. Number one, you might have heard that some medicines for IgA nephropathy have what's called a REMS program. REMS stands for Risk Evaluation and Mitigation Strategies. It's basically the FDA makes a list of rules that the prescribing doctor and the patient have to follow in order for the person to receive the medicine safely. It's become much more common in the past few years. Prior to about 7 years ago, it didn't really have a serious rules. Before that, it didn't have serious rules. Both the doctor and the patient have to register, usually online, in a safety program. The medicine's only dispensed by a few certain certified pharmacies. The person who takes a medicine in a REMS program may have to do certain things like get labs checked, get vaccinations before they start the medicine, and or they may have to do extra labs while they're taking the medicine. Although it may be a little bit more work to be in a REMS program, I really do not think that a REMS program should prevent someone from taking a medicine that can help protect their kidneys. Now, the next thing we need to talk about is approval from the FDA. So this is something else that's relatively new in the world of nephrology. A lot of medicines, including a lot of medicines for IgA nephropathy, get what's called accelerated, a kind of like preliminary approval after 9 months or 36 weeks. They then get full approval from the FDA after about 2 years or about 110 weeks. Accelerated approval is usually given for showing that the medicine leads to less protein in the urine compared to the control group. Full approval is given to the medicine for showing that the GFR, the kidney function, is actually better with the medicine compared to the control group. All right, now another thing that people should know is that most of the research trials, the people had to have a GFR of at least 30 to get into most of the research trials for the medicines we're about to see. A medical insurance company may not pay for the medicine if a person's GFR is less than 30 and possibly less than 25. All right, true or false, everyone with IgA nephropathy that has evidence of kidney damage can get and should get a supportive or foundational medicine to treat IgA nephropathy. True or false? Feel free to answer in the comments. Excellent. So I think I mentioned this before, but the answer is true. Sometimes the way I pronounce a new word in my head is not the way the word is actually pronounced. So I have to be very honest and give a disclaimer that many of the medicines I'm going to talk about, I have not heard yet from the company that makes the medicine how it's pronounced. If I mispronounce the word tonight and we find out in months or years from now that it's pronounced differently, I apologize in advance. All right, so let's start with the supportive treatments that are available. So I'm going to have some pictures over here on the right that are going to help the audience tonight and the audience after the fact understand. So this green square, as I think everyone remembers, is the kidney protection. Kidney protection is for anyone and everyone who has damage to the kidneys. Single protection will be, it helps the kidney in one way, and then I will have whether the medicine is a pill or an injection, and then I will have whether or not it's in a REMS program. So let's start with something that pretty much everybody has probably heard before, RAS inhibitors. So RAS stands for renin-angiotensin system inhibitors. Renin and angiotensin are hormones that increase the blood pressure, and they are very often elevated in people with IgA, especially people with IgA and hypertension. The two types of RAS inhibitor classes are ACE inhibitors and angiotensin receptor blockers, or ARBs. They decrease the blood pressure and they decrease the stress on the kidneys by telling the kidneys to do less work and by decreasing the protein in the urine. A person can take these medicines even if they don't have high blood pressure, but you do need to watch out for low blood pressure symptoms. Now, whenever you tell the kidneys to do less work, they clean the blood a little less and the creatinine might go up. This does not mean that the kidneys are weaker. In fact, this might even be a marker of success, that the kidneys are working less hard. These medicines can be used in combination with an SGLT2, and they can be used in combination with one of the medicines that only treats endothelin antagonists, but they get to be stopped or exchanged for one of the medicines that's a dual angiotensin blocker and endothelin blocker, which we're going to see in a second. ACE inhibitors and ARBs are FDA approved to treat all people with kidney disease and protein in the urine, but they are not specifically treated for IgA nephropathy, although clearly IgA nephropathy falls into the category of kidney disease and protein in the urine. All right, now again, this is another supportive treatment for everyone. Farxiga and Jardiance are the brand names of two medicines in a class called SGLT2 inhibitors. I call them the salt and sugar pills because they make you pee out salt and sugar, which decreases the stress on the kidneys. Again, they protect the kidneys in one way. They're a kidney protection medicine that can be used in any and all patients with damage to their kidneys, and they are also a pill. They were originally used to treat diabetes, and it was found that people that took the medicines did better. So eventually they were tested in people who did not have diabetes, but did have protein in their urine and kidney disease, including people with IgA. They are now FDA approved to treat all people with kidney disease and protein in the urine, including people with IgA nephropathy. Now, many people will notice that after they start taking the medicine, their urine analysis will be positive for sugar for the first time. Do not be surprised. This is how this medicine works to decrease the stress on the kidneys, by making a person pee out sugar. This medicine can be taken in combination with an ACE or ARB. I made these slides more than a week ago, but it can be used in combination with an endothelin antagonist, and I have already used it in combination with one of the endothelin antagonists, ARB combinations, called Filspari. They are expensive and they do require prior authorization. All right, Filspari. So this is a medication that is specifically approved and has full approval for IgA nephropathy. It blocks two hormones that cause kidney damage. So it's the only one that does double kidney protection. It is a kidney protection medicine and can be used in just about everybody who has damage to their kidneys. It is a pill and it has a REMS program. Now, the one thing that I kind of respect a lot about this medication is that it's the only one that was compared to the current standard of care in ARB. Every single other medicine that we are going to see tonight, including the ACE inhibitors and ARBs, were actually compared to a placebo. So I'm very impressed that this study did that. Now, this is another medicine that gets to be exchanged. So if somebody is taking an ACE and ARB and are not at their goal, you can exchange Filspari for their medicine rather than adding it on. It is recommended by the 2024 international guidelines. All right, now I'm going to tell you how up-to-date tonight's talk is. This Van Raffia medication, which might be pronounced differently, I don't know, was just approved by the FDA and given that accelerated, that temporary approval 4 days ago on April 3rd. So this is the newest medicine that has been approved. It blocks only endothelin. It's a single kidney protection medicine. It is a kidney protection and should be able to use in anybody who has kidney damage. It's a pill. You must also take all the other medicines that you're already on without being at goal. So this is an add-on medicine, not an exchange program, but it has no REMS program. You won't see the safety first sign over here. All right, so this is my current treatment protocol in the year 2025. And again, I made these slides weeks ago. So my current protocol, which is based on the KDIGO guidelines, is usually when somebody has more than 300 of protein in the urine, I start an ACE inhibitor or ARB. Personally, I pretty much 100% use an ARB because I think it has fewer side effects. If someone does not meet their goal on just the maximum dose of an ARB, I add the SGLT2 inhibitor, which is Farxiga or Jardiance, to the ARB. So they're on two medicines. If they still have protein in the urine, I stop the ACE inhibitor or ARB and I add sparsentan, which is that Filspari medicine. So I exchange Filspari for the ARB. All right. So once again, these are based on the KDIGO guidelines, which recommend ACE or ARB first line, adding the Farxiga or Jardiance if still not at goal, and then exchanging the sparsentan or Filspari for the ACE or ARB if they still are not at goal. At the exact same time that you are using these kidney protective or nephroprotective medicines, you are also working to get the blood pressure down. So if a person's blood pressure is not at goal while they're getting these kidney protective or nephroprotective medicines, you're also giving extra blood pressure medicines to get the blood pressure down. All right, even with the best care, some people with IgA nephropathy will still get kidney failure. All right, shall we go on to immunosuppression and update some of our 4-hit model? All right, so once again, like I said before, the green square represents kidney protection or nephroprotection. It's the supportive care that everyone can get. This works mostly or almost exclusively on hit 4, trying to decrease the stress on the kidney, on the glomerulus, on the microscopic filter. Now we're going to talk about immunosuppression. Immunosuppression is meant to decrease the galactose-deficient IgA, to decrease the formation of those immune complexes that float through the blood and get stuck and clog up the glomerulus. The immunosuppression is going to try to prevent the immune complex inflammation, permanent damage in the kidneys. So again, you can do both of these at the same time. Like I said, everyone gets supportive or kidney protection medicines. Some people or many people also need the immunosuppression, especially when they have aggressive IgA. So what tells us when to use immunosuppression? Is it the amount of protein in the urine or is it the blood in the urine? Having blood in the urine is an extraordinarily highly debated and controversial topic in IgA nephropathy. I think that people are very passionate one way or another as to whether blood in the urine means active immune system activity or not. I do think that when someone has no blood in the urine and has a lot of protein in the urine, I believe that's more consistent with old damage from previous scarring and less likely from current active damage being done by the immune system. All right, none of our prognosis prediction tools, like the MEST score or the IgA prediction model, can tell us which medicines are best, and we often need an individualized treatment. All right, let's go back to the true or false. People with normal kidneys and no diagnosis of IgA nephropathy will have no galactose-deficient IgA in their blood. True or false? So it looks like I finally got a harder true or false question. But the answer is false. Believe it or not, many people, including very healthy people with no kidney disease, have galactose-deficient IgA. Having just one hit of the 4-hit IGA nephropathy model is not enough. You actually need to have all 4 hits before you get IgA nephropathy. True or false? Finding very high levels of galactose-deficient IgA in the blood can replace a kidney biopsy to diagnose IgA nephropathy. True or false? So once again, good job in the comment section. The answer is false. True or false? In someone with biopsy-proven IgA nephropathy, finding very high levels of galactose-deficient IgA in the blood correlates with more aggressive IgA nephropathy. True or false? Once again, good job in the comments. The answer is true. Hopefully someday the galactose-deficient IgA lab test may become a marker for people with IgA nephropathy. As of today, the day of the talk, it's not yet commercially available on like a wide basis for us to measure that and follow it as a response to treatment or a risk of flare-up or anything else. All right, now everybody remembers hit 1 and hit 2. A plasma cell can make a galactose-deficient IgA antibody when trying to fight a virus or bacteria, and the plasma cell will make an immune system antibody that attacks the galactose-deficient IgA. So now let's expand that. What we have on the screen now, pardon me, is kind of what we've talked about so far. But we need to add the next step. So there are B lymphocytes called B cells that start in the lymph nodes and travel in the bloodstream. B cells become plasma cells. Plasma cells make antibodies. So remember that IgA nephropathy, or excuse me, IgA antibodies are mostly made in the respiratory, GI, sweat glands, tear ducts, and more. They're in what's called the mucosa, sort of like that wet skin that you find that sort of like connects with the outside world, which is not our normal skin. Lymph nodes in the respiratory and GI tract are the most common place where galactose-deficient IgA antibodies are made. Some of the B cells in these lymph nodes become plasma cells that make the galactose-deficient antibodies. Some of the B cells in these lymph nodes become the plasma cells that make the immune system antibodies that then attack the galactose-deficient antibodies. If we can suppress either the B cells or the plasma cells or both, we should be able to decrease the amount of galactose-deficient IgA and the immune system antibodies. Now, we should point out that the mucosal lymphoid tissue, like I said, is mostly in the lymph nodes of the nose, the lining of our bronchi, which is like our airways, and our GI tract. All right, true or false? In IgA nephropathy, medicines that suppress the immune system are likely needed at the time of diagnosis and during flare-ups. True or false? I was going to say this may be another tough question, but the answer is true. So the most common time that we use medicines that suppress the immune system are at the time of diagnosis and during a flare-up when the immune system is likely attacking the kidneys and giving symptoms. True or false? Medicines that suppress the immune system may be able to be stopped when the immune system is not actively attacking the kidneys. True or false? So it looks like we have a little bit of a disagreement, but the short answer is once again true. I hope that even though the supportive or nephroprotective medicines might need to be lifelong medicines to protect the kidneys, I hope that medicines that suppress the immune system will only be necessary when the immune system is actively attacking the kidneys during flare-ups of the IgA and probably a diagnosis. So now let's get into the specific medicines. So the medicines that have been used for 50 or 60 or more years, prednisone. Prednisone is a very broad anti-inflammatory. It is a medicine that can be prescribed by any doctor. It is not FDA approved to treat IgA nephropathy, but it has been used for years or decades to treat IgA nephropathy. There are a very long list of side effects, but it is cheap and easily available. A lot of the criticisms of prednisone is that at the time that it was used in IgA nephropathy, it didn't do a lot of the advanced testing that the newer medicines have done. Now, going back, it looks like prednisone probably does lower galactose-deficient IgA. It just was never done or evaluated in a randomized controlled trial. A lot of the randomized controlled trials also used very high doses of medicines that gave people side effects. And one of the criticisms was that future flare-ups still gave people chronic disease or progression of disease. And that happens even with the current medications as well. So I do feel like prednisone and methylprednisolone, the two most commonly prescribed steroids, really got a bad rap. I really think they got a worse reputation than they deserve, possibly because some of the newer medicines that came out wanted to compare themselves to these older medicines. The truth is that tens of thousands of people have benefited from these medicines, tens of thousands of people with IgA nephropathy. And I do think that a lot of people, myself included, have a regimen that works to treat IgA nephropathy that does not cause the side effects from those very high doses. Now, again, this probably does treat all of the hits because, like we saw on the previous slide, a lot of people call steroids the shotgun approach, where you block a lot of different things. And blocking a lot of different things may have some benefit, but that's also what leads to the increased side effects, especially at the higher doses. Now, Tarpeyo is a medicine that is FDA approved to treat IgA nephropathy. In fact, it was the first medicine to get IgA nephropathy specific FDA approval. It now has full FDA approval, and it advertises itself sort of as the lymph node medicine, as the steroid that goes to the lymph nodes. Now, they did have research, and it was a randomized controlled trial, where they showed that the galactose-deficient IgA levels were lower. It was compared to a placebo. It was not compared to prednisone. And I do question whether or not that was the true standard of care for IgA at the time it was done. I do think that in my personal experience, a lot of my patients have had side effects similar to prednisone, even though the randomized controlled trials reported side effects that were less than prednisone, even though this medicine was not compared to prednisone. So it's a little unclear why they're able to say fewer side effects compared to historical controls, but they do. I know that some doctors have had fewer side effects than prednisone. I have not. The KDIGO guidelines also acknowledge that just like prednisone, one single course of Tarpeyo is not sufficient. All right. Now, the thing that I think we need to understand is that once you make an antibody, it's yours to keep. For anyone on the webinar tonight that's old enough to remember the game show Wheel of Fortune in the olden days when they used to go shopping after each round with their money and buy all the knickknacks, the host would always say, once you buy a prize, it's yours to keep, even if you got a bankrupt or something. Well, the same thing is true for antibodies. Once your plasma cells know how to make an antibody, you can make that antibody for the rest of your life. So once your body knows how to make a galactose-deficient IgA antibody, you can make it for the rest of your life. All right, true or false? B lymphocytes or B cells turn into plasma cells, and plasma cells make antibodies. Go ahead and answer in the comments, true or false. So once again, good consensus from the audience. The answer is true. All right, true or false? A person with biopsy-proven IgA nephropathy and 187 milligrams of protein per day in the urine is an excellent candidate for a medicine to suppress the immune system. True or false? Once again, I see a lot of good consensus in the chat. The correct answer is false. That's actually a very low level of protein in the urine. I'm not sure that I would give somebody a medicine that suppresses their immune system for that low level. All right, now we're going to update our HIT 1 and our HIT 2 even more. We've talked about plasma cells making the galactose deficient antibodies. We've talked about the plasma cells making the good immune system antibodies. We talked about how B cells become plasma cells, but now we're going to talk about two chemicals, one called APRIL and one called BAFF. These two chemicals actually stimulate the plasma cells and the B cells. As you might be able to guess, the B in BAFF is for B cells, and BAFF stimulates and helps the B cells. APRIL stimulates plasma cells and helps the plasma cells survive. APRIL works more on plasma cells, BAFF works more than B cells. But like the arrows show, there is a little bit of overlap where APRIL has some effect on B cells and BAFF has some effect on plasma cells. This happens both in the lymph nodes and in the blood. And when doing genetic studies on people with IgA nephropathy have higher levels of these two chemicals in their blood than people without kidney disease. That's one of the reasons that companies chose to target these two chemicals to treat IgA. Now, as you can see down here, companies are developing medicines. So this blue indentation will block the APRIL. This orange triangle indentation will block BAFF, and there are medicines which will block both of them. These medicines should then suppress the immune system from making the galactose-deficient IgA and the normal IgA antibodies that make the immune complexes. It's possible that it might also decrease the immune system's ability to fight infections. So far, some of the data from the earlier phases look like these do not completely block the ability of the immune system to make good antibodies, which we like. Now, it is possible that if we block APRIL and we block BAFF and we decrease the plasma cells eventually from making some bad antibodies, there are other autoimmune kidney diseases like lupus or membranous nephropathy that might also benefit from medicines in this class. So what exactly are APRIL and BAFF? APRIL stands for a proliferation-inducing ligand. Like we said, they work mostly on plasma cells to help them survive and make antibodies. BAFF stands for B cell activating factor. It was formerly called B-Lys, which you may have heard of before, or you may find when you do internet searches. But again, BAFF works on B cells to help B cells survive longer than they probably should. In people who have IgA nephropathy, the higher your APRIL and BAFF levels are, the more aggressive the IgA nephropathy is. So what experience do we have with these hormones, these chemicals, medicines that block them? So there is a medicine in research trials for IgA nephropathy that was approved for lupus and lupus nephritis. It only blocks BAFF. So I wonder how well it will work on the plasma cells. Again, my experience for lupus and lupus nephritis, which is lupus in the kidneys, is that I have had less good experience than the clinical research trials showed. I have some colleagues, especially rheumatology colleagues, that feel that blocking the BAFF helps the non-kidney lupus symptoms. This medicine is an injection, and it does suppress the immune system. All right. Now, what about BAFF and APRIL in the future of IgA? So there are so these two medicines block APRIL. This was actually just announced 1 week ago. So again, you can tell how up to date this talk is. So this medicine submitted an application for biologics license application, which is kind of like new drug application. This medicine is a shot that might be available before the end of the year. Their data in IgA nephropathy looks good in terms of suppressing the protein in the urine or lowering the protein in the urine and suppressing the galactose deficient IgA. I am excited to see their additional data. All right, there is another medicine that blocks just BAFF in clinical trials for IgA nephropathy. These three medicines that end in tachycept block both APRIL and BAFF. Something we don't know yet, and we may never see a head-to-head study, is whether we need to block both APRIL and BAFF, if blocking either APRIL or BAFF will be good enough, or if blocking APRIL and the plasma cells will be just as good as blocking APRIL and BAFF, because BAFF has to go through B cells to get to plasma cells. In any case, these medicines are also in clinical trials for IgA nephropathy. The company that makes atacicept did have a press release which anticipates their biologics license application, which is like the new drug application, may come in the second half of 2025. So this medicine might be FDA approved in early 2026, for example. The company that makes atacicept actually did make another press release, I think last Thursday, 4 days ago, about how they finished their phase 3 trial enrollment. Now, the povetacicept is also in clinical research trials for membranous nephropathy and lupus, and the telitacicept is approved to treat lupus in China. Another option are two medicines that are going to be antibodies to the plasma cells. I worry a little bit because these might destroy or like get rid of plasma cells rather than just modulating them like the previous medicines did. In either case, one of them is an infusion, which is different, like a continuous IV infusion rather than just an injection. The other one's an injection. One of these was also tested in organ rejection. All right, now, in autoimmune disease, it's not really the antibody, but the inflammation that causes the damage. So we are going to expand on HIT4, the damage from these immune complexes getting stuck in the glomerulus and all of the inflammation breaking the filter and leading to protein in the urine and more inflammation. All right, so which part of the immune system attacked the kidneys in IgA nephropathy? You must have IgA antibodies to be called IgA nephropathy. However, C3 complement is also present. This is something we're going to talk about in more detail, but complement is not really talked about or hasn't been talked about very much for years. IgG antibodies are also present, which again, we've mostly focused on the IgA antibodies for years, but now we're giving more attention to the complement and the IgA. So what is complement? Complement is a less publicized part of the immune system. Complement, those blue rectangles, sort of float through the bloodstream in the inactive state. When they come across something that doesn't belong, like a bacteria or a virus, the complement sticks to it and activates. Once it activates, there's this process, like a snowball coming down the hill, that amplifies and makes more complement, more activity, more inflammation. And so we're going to simplify it today, but please understand this is quite a complicated process. But because this is like a chain reaction, blocking any part of the complement system might lead to less inflammation and damage in HIT4. So when the complement bumps into something, sticks to it, and gets activated, there's sort of a two-part action. The top piece above the dotted line separates, goes off, and starts to call other cells and inflammation for help. So it says, other cells, come help me attack this bacteria, come give inflammation so the bacteria dies. The second part, the bottom part, sort of turns into a hole in the bacteria, and the bacteria bleeds to death because all the inner contents leak out that hole. The complement is by far the most important part of the immune system for bacteria that have a very thick cell wall. Meningitis is one example. Because some medicines that block complement suppress the immune system, you need to get vaccinated against some of these bacteria with a thick cell wall, where complement is the number one part of the immune system that treats it or that protects us. So we do have inhibitors that prevent it from getting out of control, but once it does get out of control, it can cause inflammation and sometimes permanent irreversible damage. If it does that permanent irreversible damage to a bacteria or a virus, we're like, fantastic. But when it does it to the kidneys, we're like, uh-oh, that's not good. So don't forget that these immune complexes in the blood or in the kidney filter are abnormal. Complement attacks these immune complexes the same way that it attacks a virus or bacteria, because they all look like they don't belong. Don't forget that the top piece goes off. It calls in more cells to come attack what it thinks is not supposed to be there. So other cells will come in and eat the immune complex. Other cells will bring inflammation to break up the immune complex. The bottom part then turns into a hole, which it thinks is trying to make it bleed. We know that it doesn't work quite as well like that on an immune complex, but it does lead to a lot of inflammation. So some of this happens in the blood, but the vast majority of this immune complex being attacked by complement activity happens in the kidney glomerulus. This can lead to inflammation that can cause permanent, irreversible kidney damage. So what experience do we already have? Well, there is a medicine called avacopan, which is in clinical research trials for IgA nephropathy. It's already approved for another autoimmune disease called ANCA vasculitis. Every medicine in the complement inhibitor is in or is expected to be in a REMS program for safety. These medicines are pills, and they are immunosuppressive. Anyone who gets one of these complement inhibitors must be vaccinated to certain bacteria, like meningitis, like pneumonia, and sometimes like another type of pneumonia. Another medicine that we have is ravulizumab. It can sometimes be a once every 2 months shot, which is pretty convenient if you're going to get a shot for only 2 months. It's approved for many autoimmune diseases, and it's currently in clinical trials for IgA nephropathy. Another medication that's currently being used to treat paroxysmal nocturnal hemoglobinuria also blocks a piece of the complement system and is now in clinical trials for IgA nephropathy. Again, like all the rest, you have to get the vaccinations, and it's in a REMS program. But what about the one and only complement inhibitor that's already approved? Fabhalta. So this is one medicine. It currently has the accelerated or sort of preliminary FDA approval for IgA nephropathy. It is a pill, which again is a little bit more convenient than a shot for most people. And it also has the vaccination requirements and the REMS program. It does suppress the immune system. And then we do have one more that's in clinical research trial, which has not yet been approved under any condition. Again, expected to have a REMS program and is expected to need the vaccinations. So here's sort of our summary slide for all the medicines. The red capital letters are approved to treat IgA nephropathy. The ones that are underlined are specifically approved for IgA nephropathy. But like we said, ACE inhibitors, ARB, Farxiga, and Jardiance are approved to treat all kidney diseases, which include IgA nephropathy. Vanrafia just got their accelerated approval 4 days ago. Fabhalta has accelerated approval as a complement inhibitor. The sibeprenlimab is the one that submitted their biologic license application and may be available to be prescribed and approved by the FDA later this year. prednisone and methylprednisolone can be prescribed, but they're not FDA approved, like say Tarpeo is. All right, so let's summarize. Deciding whether or not to treat IgA depends on prognosis, mostly the protein in the urine. Everybody gets the supportive or foundational treatment that are nephroprotective or kidney protective. The most important supportive care, foundational care, nephroprotective or kidney protective medicines. Control blood pressure, ACE inhibitors or ARBs, SGLT2 inhibitors like Farxiga and Jardiance, and the endothelin antagonists. Immunosuppression focuses on blocking the 4 hits in the 4-hit model, and a few medicines now, 4 of them, have now been approved, either full approval or that conditional preliminary accelerated approval, specifically to treat IgA nephropathy, and very soon we might get a new class of medicines that can block APRIL and BAFF. All right. Is the life of a person with IgA nephropathy going off and on immunosuppression and decades of supportive treatment? I think the answer is yes. All right, so let me ask some questions to the audience. Please feel free once again to answer in the comments. Which of the following kidney diseases is unlikely to benefit from treatments to block B cells from turning into plasma cells and making abnormal antibodies? This answer was given in the lecture, so hopefully you know. A, IgA, B, membranous, C, lupus, D, focal segmental. I'll let you all vote, and then I'll give you the answer. Excellent. Everybody said D. The other 3 all have clinical trials using medicines to block APRIL, BAFF, or both. Which of the following is a chemical that helps turn B cells into plasma cells and help plasma cells survive longer? March, April, May, or June? Good. I think once again, people were paying attention. The answer is April. And then I'll ask you the toughest question, maybe, of my 3 multiple choice. What does BAFF stand for? I'll let you read them and take a guess. What does BAFF stand for? All right, there's not much fooling this group. It was A. All right, now I took like all of the questions that were submitted and I tried to take the ones that were asked the most, or like the topics that were asked the most, and tried to come up with some answers. So question, will we someday use the blood levels of galactose-deficient IgA, APRIL, and BAFF to assess aggressiveness, how they're doing guide management? I think so. So I'm not sure that the levels will ever be 0. Like we've talked about, even people that don't have IgA nephropathy have some levels, but I do think that when the levels are high, that could be a problem. And that with treatment with immunosuppression, I hope to get the levels down to a baseline level. If we see a big jump in the level, I do think that suggests that the immune system is active and that there's a flare-up, and or that there's a flare-up coming soon. All right, how do we use the kidney biopsy MEST C-score? And do people with E0 and C0 need medicines to suppress their immune system? So I do think that we have to determine, first of all, when was the biopsy done? A recent biopsy, yes, this is accurate. I think that in a lot of the research trials of the medicines that I just described, the biopsies were done years before the trial. So I do not think that the MEST C-score done on a biopsy 5 years before the research trial can tell you anything about how somebody responds to that MEST score. Now, that being said, the recent one I do think distinguishes between activity and chronicity or permanent scarring. Now, in the interest of full disclosure, I usually offer at least 1 course of immunosuppression after a kidney biopsy, because clearly there was enough immune activity to make me do the biopsy, even if there's a E0 and C0 on the biopsy. Is there a point of kidney disease when IgA should never receive treatment? So I lean towards no. I always give supportive and foundational care, and I do usually offer at least 1 course of immunosuppression after a kidney biopsy, because I feel there was enough immune system activity to make me do the biopsy, even if the 2 letters that suggest active immune system activity are negative. Can we use immunosuppressions that work on more than one of the different hits of the hit hypothesis? Probably. So you probably could use one on like 1 and 4, for example. I don't know if we're ever going to do a randomized controlled trial that uses 2 of them and actually compares to just one of them. But I also wonder if just one immunosuppression is enough. If we have this new class of medicine that inhibits or APRIL or BAFF or both, is that going to be enough? And maybe just one immunosuppressive medicine is going to be good enough. Should we just start supportive care and immunosuppression without a biopsy? I lean towards no. Diagnosis of IgA needs the kidney biopsy. We want to make sure that the person doesn't have a genetic disease or a different autoimmune disease. And it also tells us prognosis, how much is permanently scarred, and whether or not to use immunosuppression. All right, can people with less than 300 milligrams avoid all medicines? Maybe. I still think that supportive or foundational treatments can be used in IgA nephropathy if there's evidence of abnormal labs, which it would include an example of somebody with like 200 milligrams of protein in the urine, ACE, ARB, SGLT2, or even like the endothelin antagonists may be appropriate. I probably would not use, or definitely not use, immunosuppression. Does blood in the urine suggest that a person with IgA should get medicines for the immune system? So maybe yes. Like I said before, this is an extraordinarily debated medicine. I think that a lack of blood often means that it's an old attack and not a current attack. And I often do not use medicines that suppress the immune system when there's a lot of protein in the urine, but no blood, because I personally think, based on experience, that's more likely that that's scarring and not active immune system activity. But again, very debated. Does IgA nephropathy damage a transplant kidney? Yes. When people with kidney transplants get biopsies for whatever reason, people who have IgA as the cause of their kidney failure will have IgA deposits on the biopsy. However, although it can happen and does happen, a transplant kidney rarely fails because of IgA nephropathy, because of the anti-rejection medicines which suppress the immune system. I suspect that supportive or foundational medications, which haven't necessarily been tested in IgA after transplant, would also work. And what about the genetics of IgA nephropathy? So like I said a little bit before, when they took people with IgA nephropathy and they checked their entire genome, they saw a few things. 2 of the things that they saw was that APRIL and BAFF levels were higher. This suggests that those could be targets for treatment, which is one of the reasons that pharmaceutical companies made medicines that targeted those 2 chemicals. A child is not guaranteed to get IgA if the parent has it, although family members of people with IgA have a higher chance of IgA than the general population. All right, if you'd like to vote one last time, I know last time we took a vote on what the next topic should be for the next webinar in our series. As I think people remember, the overwhelming majority of people chose treatments, which is why today was treatments. But if anyone would like to vote on potential for next topic, please feel free to go ahead and vote now. Okay, thank you very much. All right, I guess if there's time, we can take a little bit more of the questions in the chat. If anybody has any questions that weren't one of the like 8 to 10 questions that I pulled out of the questions when people registered, or that we didn't cover, because I did try to cover some of the other questions in the talk itself. When people were asking about how fast do you progress through stages and stuff, I tried to include that. What does the future look like for regenerative medicine, restoring podocytes, etc.? I think that's definitely something of the future. I'm not sure that there's anybody who's far enough along in regenerative medicine to replace podocytes, but I think the problem with your question is that it's not just the podocyte. So when someone with IgA nephropathy or any chronic kidney disease has inflammation, the podocytes get damaged, Those are the little cells that are in the filter that we talked about in the pasta strainer. The blood vessel cells are damaged, the in-between cells are damaged, etc. Wasn't Ozempic just approved by the FDA for the treatment of kidney disease? I didn't see that specifically, but one of the things that I believe we know about Ozempic and kidney disease is that we're not convinced that Ozempic actually touches the kidneys and fixes them. What we do know is that when I mentioned the top 5 things that stress the kidneys, diabetes, Ozempic and Mounjaro, and the 2 brand names for weight loss as well, they treat diabetes. Number 4 on that list was obesity. Those medicines treat obesity. And when you lose weight, your blood pressure and your cholesterol often get better as well. So although we don't know for sure the mechanism of action, one common hypothesis for the mechanism of action is that Ozempic treats 4 of the biggest risk factors for kidney disease, and that's why kidneys get better. If there is FDA approval to treat people who have kidney disease that don't have those other like metabolic syndrome risk factors, that would be a big deal. All right, well, if there aren't any more questions, oh, one more question. It seems that a flare-up could go undetected. Does that concern you? Well, the short answer is yes. Like I said before in one of my slides, any flare-up is like a punch to the kidneys. Now, it's true that many people with IgA have symptoms when they have a flare-up. Their urine changes to look either darker or cola-colored or tea-colored or even bright red. I do worry about some undetectable flare-ups, which is one of the reasons that I talked about the blood in the urine. There is some evidence that having microscopic blood in the urine gives people a worse kidney prognosis in IgA than not having microscopic blood in the urine. And I think that gets back to the very controversial symptom of microscopic blood in the urine. Does that mean that people are having very small flare-ups represented by that microscopic blood in the urine, and that people with microscopic blood in the urine should get medicines to treat with immunosuppression to treat active IgA? So your question, I think, is exactly that. And although we have no definite answer, that's the gist of it. Somebody did ask about the risk of measles with iptacopan. So measles is a virus. Measles is a live virus vaccine. Anybody who's immunosuppressed in general can't really get a live virus vaccine. So you should be off iptacopan or really any other medicine on this list that suppresses the immune system if you're going to get a vaccine against the measles. I don't think that measles would be like higher risk than say like meningitis or some of the pneumonias because those are the thick-walled bacteria. How do you estimate the future eGFR slope based on historical blood work? So that's a really tough one. There are some formulas that you can plug into. So that IGAN prediction tool can work up to 80 months. There is a kidney risk failure equation that works up to 5 years, and you use GFR and protein in the urine mostly along with like age and race, ethnicity, and stuff like that. They don't give you the slope per se, but they give you the percentage chance of having a GFR of, say, 10% or a GFR of half of what you have now. It's more like a statistical percentage. What if you see more protein in the urine after transplant? Is this a flag that IG is attacking again? It could be, but there are many reasons that someone could have protein in the urine after transplant. Just like protein in the urine of your original kidneys, a person with a transplant kidney and protein in the urine needs a kidney biopsy in order to find the diagnosis or to find out why they have protein in the urine. Recurrence of IgA is one reason that someone who has IgA nephropathy could have protein in the urine after transplant, but there are lots of other reasons for protein in the urine, which would be treated differently. So you must have a biopsy. So the thick-walled bacteria on iptacopan, it's a real risk. So as a class of medicines, when the first medicines in that class came out, it did not have the requirement for the vaccines. And a lot of people got serious meningitis infections. There are reports of people getting other thick-walled bacteria infections. Gonorrhea is one of them and pneumonia. So it's Streptococcus pneumonia and Haemophilus influenza pneumonia. And those are more commonly reported in people who get that class of medicines that inhibits the complement inhibitors. Specifically for iptacopan, by the time that medicine was in IgA nephropathy trials, they knew that people needed vaccinations against meningitis, Streptococcus pneumonia, against Haemophilus influenza pneumonia. So in order to get into those research trials, people were already vaccinated, which made the risk of those infections much higher. Excuse me, much lower than the original studies that were done prior to using that vaccination or those vaccinations pre-trial or pre-medication. The gonorrhea actually still is a problem because there is no vaccine for that. So people that are sexually active need to be careful not to get gonorrhea while they're taking a complement inhibitor. All right, well, it's just about 8:30, which means it's been about an hour and a half. So I would like to thank everyone once again.